So, Gloria Prado from Colombia. In Colombia, we have implemented universal health coverage for more than 20 years. And the coverage rate is really high. But what we see now is that there is a huge gap between the coverage on paper, which is over 90%, from real access to care. So referring back to the physician salary, I think this is a door that we open for brain drain of healthcare providers in Indonesia. They're not satisfied with the salaries. And also, I would like to know what strategies have you thought to tackle this issue that the wealthiest part of the population don't want to contribute more.
So the first question really has to do with
from Brazil or from
Colombia.
Colombia.
Right.
From Colombia, the whole
So,
experience of losing
Right.
physicians.
Right, I know. Colombia is lucky because you have surrounding countries, so the bread drain can be there. But Indonesia have the culture. It is important to stay together in a country, although we do not eat. Something like that. It is the philosophy of Indonesian life. So better to stay at home. Even they no rice, no eating. So if although they are not satisfied of the payment of the fee as the medical doctors, they will not go to US. First, it is too far, and then second, not always be accepted in US. So what I mean is, there is no brain drain. Of course, 1 or 2% is yes, but not so many. Not like India, China, or maybe your country.
Colombia.
Yeah, it's not like that. So Indonesia is not problem of the brain drain because of the philosophy of living.
But the possibility for go ahead.
So my point is because right now there is not like I'm thinking about long term.
Oh yes.
Because our system has been like this for more than 20 years, so the results are really showing now.
Right.
So then going back to the other question, what have you thought about like as a strategy to make the wealthiest part of the population to contribute more to the system?
Okay, I'm thinking, but I'm not doing because my job is not in that case. But of course, that actually we have to go to the regulation that the rich have to pay more. And now also the government are thinking how the tax for tobacco, tax or sin tax should be allocated for this system, so the system can have more money. But again, the rich, I think they have to pay more. But now, many rich people in Indonesia, they pay just little because it is, the premium is too low. They pay.
But it's not just premium; it's also in taxation.
Yeah, also in taxation. But now we have a progressive tax, and recently the tax is very, very strong and very, strict. Even myself, just recently we have to pay double because the Minister of Finance is very strict. Just recently,
Right.
because now it's very strict. That just recently, not long time.
The ability to collect tax in
Yeah,
Indonesia has changed very dramatically
Now
in the last
now, yeah.
decade.
And again, I think we have to publicly debate that the rich in Indonesia not yet pay appropriately according to the ability to pay. So I think in the debate and also in the regulation we have to change.
And on the issue of sin tax, of course, smoking is not a sin. Next. Last question.
All right. So I want to disclose first that my perspective is from like for-profit perspective. So I came from United Health Group. So so the first one is I want to talk about or ask about has been any discussion to give capability for BPJS to have like commercial activity? Because to give you perspective about United Health Group, we manage 130 million people in the US, and our revenue is about $200 million. But $100 million itself is coming from commercial value that we built on top of insurance products. Right? So has been a discussion on BPJS because it's like given that capability for the country to provide funding for the BPJS. Been a discussion to create something that on top of insurance products.
Okay, so I think actually there is opportunity. Yeah, but
that's why he's here.
Yeah, this is here. But I think the sense of business and commercial US is much more compared to Indonesia. So the Indonesia, when trying to develop the system, it is like not for profit. So the way to think is not really every opportunity and how they to get money, but it is not the way to think. So therefore again opportunity is there. Therefore I think if you would like to grasp and use use this opportunity, we can invite you there over there. Again, I think actually like BPJS is not for profit by design. Although there are many data like United Health can be sold and can produce the money, but they're not thinking like that. I'm sure actually there are many opportunity if they know. Unfortunately, first maybe they do not know. Second, the philosophy is that is not for profit. They have to serve the community, the people. So this is the different philosophical thinking.
Has been any discussion in
Not yet.
Not yet.
Yeah, not yet. But I think if you can expose and introduce, then maybe they will thinking in the future.
I just want to make one additional comment on behalf of the interest in the ethics of money and the ethics of the hospital, because I think is Sandeep still here? There in the ethics course that the Harvard bioethics faculty, together with the Gautama faculty and bioethics center on Biotica and Humaniora, gave in January, there was a case that Sandeep and Aziz designed, in which the problem of forcing the hospital to lie and distort what they were doing in order to get enough money to cover the costs of care and the cost of the pharmaceuticals. And actually the physicians here in this country also talk about having to actually lie about what a diagnosis is in order to get the proper care for their patients. So these highly rationalized economic systems that are created for healthcare insurance, universal healthcare insurance or any kind, if too structured, are structured so that they punish the institution or punish the practitioner, create people who are not honest and feel guilty about not being honest, and undermine the trust in the institution that the clinician has in the institution, that the clinician has in the health insurance scheme, and disrupt what's going on between clinician and patient. So there's a very complicated set of problems
At the
that
clinical
at the clinical that gets started at this higher insurance level that gets played out at the clinical level and can be very disruptive in terms of delivering quality of care. So I think that I hope you're able to solve your financial problem, and also I just think that the U.S. system is in such dire straits that you don't want to replicate this one.
Right.
I can give you maybe another statistic. We just had project with payment integrity, right? So in the field of durable medical equipment, report from CMS saying that 45% to 59% improper payment rate for CPAP machine and oxygen tank in the US. 50%. This is a huge number, right? It's happened here, and the US healthcare system thrive by private companies like mine.
So like I said, actually, if in US the fraud is consumed around 10% of the healthcare expenditure in US, but I'm sure Indonesia is much more than that.
Yeah,
But the problem is to identify that is not easy, because we have to have someone who knows in medical complexity situations, but at the same time have to know the financial management and how to track whether it is actually fraud or corrupt or what.
And if you take into the kinds of examples that were discussed in the bioethics meeting, these were physicians who you could call it fraud or because they were, but what they were doing was advocating for their patients. Advocating
so
to get the kind of care
exactly.
that they thought their patients.
This is not fraud. I would say this is This is the system not being designed with enough flexibility for a clinician to practice quality medical care in the time frame, etc. Rather than making money off of, we know that many cases in which if equipment is bought, money goes into somebody's pocket, but that's different, completely different. So I wouldn't even call that fraud. And I think that when they're calling this, Medicare fraud, I think that Medicare fraud is maybe a little bit of this physician stuff. What's happening now is that these physicians aren't being harmed, except in terms of their personal sense of personal power, their cultural power. And also their sense of their professional ethics. So I think that you need to throw it all together in one basket. It's a different kind of thing. Anyway, it was great talk. Really loved it.
Okay, I think it is very interesting, but very complicated and difficult to have approach to solve the problem, the balance between the call of the professional as the doctor and also the administration.
Okay, thank you very much.